Thank you. Okay, so there's a need during focus ultrasound thalamotomies for better visualization and differentiation of the lesion. This is particularly true when patient feedback and thermometry may be ambiguous or error-prone. And at these points, surgeons like to take a T2 weighted image, and they're looking for that kind of white spot, or that's the T2 weighted lesion on the image, this white spot that will show where the lesion is. There's some problems with using this approach. First, it can take up to 30 minutes or longer for the edema to fully develop so you can visualize this lesion. And second, T2 weighted images help you visualize edema, which is not exactly equal to ablation. So our hypothesis is that diffusion-weighted MRI may provide a better visualization of the region of the lesion that's been thermally coagulated, and also may better differentiate between edema and actual tissue that's been ablated. And this is analogous to how diffusion-weighted imaging can improve a diagnosis of ischemic stroke. Particularly, we hypothesize that we can use diffusion-weighted imaging to visualize the lesion within 5 minutes after an ablation. And we're hoping for something that would look like the image that you see on the right-hand side. There's some technical challenges to this approach, which I'll just go over very briefly. First, the transducer has a very large field of view that can make it challenging to do high-resolution diffusion imaging. And second, cardiac pulsations of the brain can introduce signal loss. But the most challenging barrier to this kind of imaging is that for some versions of the transducer, including the one that we have at UVA, there's some very severe inhomogeneity in the RF transmission field of the MRI scanner. In particular, the black band that you see on the image is constrained by a standing wave effect to be essentially zero. And so when you try to image a plane that's close to that black band, you get a lot of signal loss. So for example, these are single-shot EPI images, just your standard diffusion EPI images of the transducer. You get a lot of signal loss. So we have a kind of intermediate solution that we hope to iterate and refine, and that's just simply at the end of treatment to drain the water bath. And that removes a great deal of the imaging difficulties, and depending on the treatment workflow, you can drain the water pretty quickly and get a rapid measurement. And then we've developed a method to correct for the cardiac pulsations, the signal loss from the cardiac pulsations of the brain, and sharpen the image, which you can see on the right-hand side. So the results, we've been able to do this on 2 people so far, which is a small number. But for both people, both patients, we have a rapid acquisition of the images, and we can see improved contrast on the diffusion-weighted images compared to the T2 weighted images. And we don't quite have enough data points to provide a time course of the development of the diffusion-weighted contrast of the lesion. So the advantages of this technique of draining the water bath is that you can acquire these images fairly rapidly after sonication. Draining the water bath does remove the primary impediments to diffusion-weighted imaging, and it also gives you a large increase in your signal-to-noise ratio, and the contrast so far seems to be reasonable. The only drawback, the main drawback, and what we need to improve on, is that if you drain the water bath and then if you want to fill the water bath up, you've reintroduced gas to the water bath and you have to wait to degas it. So I feel that there's still some refinement that needs to be made on this technique. And lastly, I'd like to thank my collaborators, all the people who've helped me, and our funding sources. Thank you very much.
Dr. Ed, this is excellent work. This is amazing. This is the direction we need to take for sure.
Thank you.
And we've been able to use the similar kind of removing the water and being able to acquire some images as well. Do you recommend using additional coils as opposed to the body coil that we're using? And do you think there will be integration of the coil design into the transducer itself or some other way into the membrane would improve this kind of imaging so that we can even acquire more directions of diffusion to really study the lesion site?
The body coil better coil design would certainly improve the image. That kind of black band is caused on the transmission side. So the thing that would really fix the problem would be having a new transmit coil. That's more technically demanding, but a receive-only coil that maybe could be close to the patient's head would really improve the SNR and make these measurements much more easier to accomplish.
Great, thank you.
Yes.
Thank you very much for your talk, very interesting. You just answered to my first question. It was about the coil you were using. It's the body ref coil, right?
Yes, that's
and
right,
just
yes.
a comment, because we achieved in the last few years some experience with a 1.5T MR unit that is using a dedicated coil. It's a 2-ring coil on the side of the head that is giving us a very good signal. And thinking about the edema versus the real lesion, and since the diffusion is very sensible in detecting such a difference between edema, if it's cytosolic or vasogenic edema, from our experience, if you can scan a very good T2, it's not a 30-minute T2 like for the body ref, we scan it in 3.5 minutes, you can already see the lesion just after the last high powerful sonication that you had without any edema all around. And you can also see the dark spot that is somewhat typical of the lesion in the hacked face. That is, so probably the best would be, as also the other colleagues were suggesting, to try to introduce some kind of coil inside the membrane as for the 1.5T units, or some other kind of coils that other sites are using to increase the signal-to-noise ratio. Because from our experience, seeing the lesion during the treat could give you a good result, very helpful in taking the decision to what you have to do next after the last sonication you had.
One follow-up question. Are you acquiring those T2 images after the final sonication, or do you see that
also
nice
during,
differentiation all the way
also
through
during the treatment.
each sonication?
If the patient is referring some strange collateral effects and we want to check if something's going on, we have enough resolution to see what's actually going on.
And you can see the differentiation of the 3 zones of the lesion early on.
Yeah, we have a poster about that. Maybe we can discuss it later. Okay.
Yes. Very quick.
Oh,
Comment
thank you.
about that. At 1.5T, the black band's going to be in a different location. So it's not just a matter of having an external coil. Their signal loss is not where yours is at 3T.
Right.
And
yeah,
the other thing is, rather than moving the water, the other thing that we've done, and I'm speaking for Kim here, you can hang bags of barium outside the outside the transducer, and it will move that black band out of the thalamus. So you may be able to get away with doing this without actually draining. The issue with draining is if you refill, if you decide you need to retreat, we've sometimes seen that the displacement in the SI direction may not be exactly what it was before.
The patient
So
said.
you could at least try to keep track of the volume of fluid, but it may not be that the skull returns to the exact same position, even though they're still inside the frame.
Has the barium been consistent? It consistently removes that black band?
It consistently moves it out of the
found
way of the thalamus. You can use it to improve SNR if you need it, but we can talk about it more if you'd like, but it may obviate the need of draining the water.
Okay. Thank you.